Welcome back to the channel. I want to talk about a new set of articles that appeared this week in Sensible Medicine. Sensible Medicine, of course, is a Substack that my colleagues and I run that aims to host a diverse set of voices in biomedicine that tries to talk about the topical medical news. And we had two zingers this week that I want to walk through. It's about, is it okay for internists, for doctors to mask forever? The first one is entitled, Is it okay for internists to wear masks forever? It's by Catherine Sarskian, who is a professor at UCLA, a geriatrician, and she has a very interesting take on this, where she argues it's actually unprofessional, it's not acceptable to keep wearing that mask forever. Now, we have a rejoinder by David Ryan, who's also an esteemed physician at the Harvard Medical School, and he writes that, he may not always want to, but it's okay if people want to do it. So let's walk through some of the arguments. I think it's a very interesting set of paired essays. So let's get started. The first point. Catherine Sarskian is not talking about if a patient asks a doctor to wear a mask. She writes, quote, most people agree that in 2024, if they ask, you should do it. She's asking, should you just go around as a matter of fact wearing a mask if no one's asking you to do it? Maybe patients are hard of hearing or just want to read our expressions, she writes. Maybe they feel masks are unfriendly or even disrespectful. Wearing a mask changes the doctor-patient relationship. I think she makes a good point. She's probably spot on that claim, and it is tough if somebody's hard of hearing. She writes, I recently spent a week attending at the geriatric ward at the VA hospital. Most of our patients served in Vietnam. Many of them have lived hard lives and are in the hospital with some combination of severe illnesses and significant social problems. Many have little social support. I gotta say, that's my experience at the VA Portland where I worked, VA in San Francisco where I worked, and the VA in Washington, D.C., and Jesse Brown VA in Chicago. I worked, I think, at 4 VAs now in my career, and I think that's absolutely true of the VA population. She says, I was happy to see the VA no longer requires staff or patients to wear masks. That's great. That's different than San Francisco General Hospital where I work, where we continue to have the mask mandate, even to this day, no breaks ever, because that's a illogical policy. But the VA at least is better than that. Patients who are coughing are asked to wear masks, and staff who are sick are told to stay home, she writes. I think that's pretty fair. She writes, I was unhappy to see that most doctors still wear masks. For the house officers, that means residents and interns, on my team, this included wearing masks in our private conference room. By the way, I'm paraphrasing what she writes. You can go to the website and see what she's writing in my ad-libbing. I hope it's kind of obvious to you all. I worked with one house officer for an entire week, and I never once saw his face. When I asked him why he wears a mask, he said, quote, I trained during COVID. I guess it's kind of a comfort thing, end quote. The physician has accepted a position in a subacute nursing facility, also known as a SNF, and he's starting to work there in July. He plans to wear a mask for the rest of his career, never show his face. She writes, hiding your face from your attending and colleagues is one thing, but the more important question is, what impact does hiding your face have on providing outstanding patient care? How does it feel for patients who are sick and alone in the hospital to never see a human face? Most of us went to medical school with a dedication to help sick people feel better. Should showing your face to one's patients be considered a minimum standard of care for people in the inpatient service? She writes, when you walk into the patient's room wearing a mask, you're saying 3 things. Number 1, we think you're a danger to us. I don't want to get sick from you. 2, our comfort is more important than yours. 3, even though I'm a physician and trained in the scientific method, I'm pretty bad at assessing risks. And I think she's making a pretty good point. The doctor must be feeling well who's wearing the mask, because she's already stipulated that if you don't feel well, you shouldn't be there. So you feel well. You're saying that wearing this flimsy surgical mask that's baggy on your face is somehow going to protect you from the patient or protect the patient from you. 2 claims that lack evidence, which we'll get into. And I think it is a barrier to proper communication, and you are disrupting that relationship. And honestly, somebody who's at the Veterans Hospital who comes in seeing you wear that mask might lose all faith and trust in you and think you're some sort of zealot doctor who's lost sight of where the rest of the universe is. The world has moved on. It's 2024. Nobody's wearing a mask anymore. Even the zealots of COVID-19 have abandoned masks. Michael Osterholm himself, a COVID-19 masking zealot, said he himself no longer wears the mask, okay? She writes this is a great point. In the early days of the AIDS epidemic, many physicians shamefully refused to touch patients with HIV. We developed universal precautions, but when the risk was real, but we reprimanded people who wanted to take more extreme measures. COVID has not disappeared. We always will have it. Internists will continue to take care of sick people. We should continue to take reasonable precautions in risky situations, but we should draw the line at extreme measures. Always wearing a mask on medical service is an extreme measure and lies outside what should be considered acceptable professional behavior. Wow, she comes in hot, okay? She comes in hot. And honestly, she might be a little hotter than me on this, even me, because I'm skeptical that it does anything, but I generally tend to allow people to do whatever fantasy they wish. For instance, I've worked at so many hospitals where I'm sitting at a desk and somebody comes in to work at the next workstation. They bust out the chlorhexidine wipes. They start wiping everything down. They got alcohol wipes on the monitor. They're wiping the mouse. They're scrubbing it. Sometimes they wear gloves when they do this. They throw the glove. They're creating a cloud of fumes, of this chlorhexidine fumes that are wafting over to my face. I'm saying, what's going on over here? Oh, well, I don't know who touched this keyboard. I was like, okay, yeah, you don't. But do you do this in every walk of your life? You go to the grocery store and you scrub it down, and do you really think this is any better than just washing your hands before you eat or touch your face or do anything later? You really think this is a useful strategy? And of course, they have no data, and at some point, they can come across a bit of a zealot, a bit compulsive. But generally, I don't acknowledge it. I just let them do whatever they want to do. I roll my eyes. I think, well, that person's a little extreme, and I move on with my life. And similarly, if I encountered someone who's always wearing a mask, I would wonder why they're doing it, but I probably wouldn't even ask, because I don't want to bore myself and get into an argument where they say, I have asthma, and then I say, what does that have to do with any of this? Well, that means I'm at high risk of COVID-19. I say, actually, exercise-induced asthma is not a high risk of COVID-19, and it's 2024, and you've had 7 shots, et cetera, et cetera. I don't want to get into all that, so I don't even bother asking. But Catherine, I think, takes a more extreme position, and I think it's a necessary position to take, because if you want to push the narrative a little bit forward, we already have a situation where nobody's doing this, nobody wants to do this, but there are a few holdouts. If you want to push it a little forward, I think her style of writing, I think, advances that cause, and I think is important to get people to remember that there's a big picture here, okay? There's a big picture, and we're providing care, and part of what caring for the patient means is showing your damn face to the patient. I really think that's true. In response, here's what David Rind writes. I've noticed that many clinicians seem to speak in absolutes more frequently when it comes to masking than other issues. As such, I'll start with a single absolute statement. With the strain of COVID that circulated in the spring of 2020, having the provider wear a surgical mask and eye protection and the patient wear a surgical mask was highly effective in outpatient setting. I started seeing patients in a dedicated COVID clinic in April 2020, and we had no access to N95s. My first morning in clinic, I saw 8 patients. 7 of them test positive for COVID. I suspect the 8th was a false negative, so he's saying they all had COVID. Over 7 months in that clinic, no one surrounded by coughing COVID patients, no staff member developed COVID, not one. Enough of absolutes. Well, here I think it's making an interesting claim. It's a claim a lot of people make. They say, well, when we did it, I didn't get sick for a year or something like that. The problem with that claim, I think, is that it's a notoriously unreliable method to draw conclusions about efficacy of products. The people who, took part in lobotomies and the people who did leeching and cupping and all these kind of failed strategies, they all have these kind of anecdotes. Well, every time I was cupping, I didn't have back pain that day, and these kind of things. That's one. 2, what does he actually think the effect size of masking is? I think if you put pressure on him to commit to that, he would say something like 10%, 15% reduction, surgical masking in the room. Maybe he'd say 30%, 40%, but I doubt he'd say 100% or 80%. The question comes up. If you have an event that occurs not just that occurs with sort of a stochastic distribution, with a heavy right tail probability, that means many COVID encounters where you come into the room with somebody with COVID, you're not going to get COVID. For instance, in household contact studies in April 2020, there's about an 8% chance somebody living in your house is going to get COVID if you have COVID. So that's the average probability, but there's a tail. In some situations, like a chorus choir, it's possible that 40 people out of 50 people get COVID. It has a unique distribution of spread. And if you have that, and you start to see if your individual experience can allow you to see whether or not you've shifted that distribution of COVID-19 spread, I think this N of 1, provider clinic example, it's really weak evidence. I mean, if you start to think about that effect size, the sample size you would need to even see such a difference, it's much more likely he didn't get COVID or nobody got COVID in the clinic out of luck. And probably if they masked or didn't mask, if you had 1,000 clinics mask and didn't mask, a lot of the clinics would not get any COVID spread out of luck. But some are going to get explosive spread. It just didn't happen to occur in this one clinic. But that's why, of course, this whole thought experiment is why, of course, we do clinical trials, okay? This is why we do clinical trials. We don't rely on people's anecdotal experience because human beings are not very good at finding with the naked eye effect sizes of 15% or 20% relative risk reductions. We're not that good, especially if something has maybe there's a 10% chance he was going to get COVID if he lived with that person for a day or two and they had COVID. So what's the probability to get COVID in a 15-minute encounter, even if they're coughing? I don't know the answer to that question. I think it's been poorly documented. But if you start to think about probability this way, I think you would conclude, a rational person would conclude, is that that's not actually evidence. He writes, I suspect that masking patients and providers is somewhat effective in reducing transmission. If you think there are adequate data to prove the statement false, please cite the high-quality evidence. I think that's a bit bizarre because the burden of proof is on he who lays charges. The person who thinks it has a benefit should show it has a benefit. But I think all of this is a little bit off the mark because, we're talking about 2024, right? We're not talking about 2020. 2024. She's writing her article about 2024. So whatever his experience was in 2020, you really, I just don't see how it advances going forward. But this is where I think it gets quite interesting. COVID was my second pandemic. I was in training as the AIDS epidemic hit. I watched clinicians refuse to walk into patient rooms, refuse to touch patients without gloves, refuse to perform procedures. This behavior was medically harmful and unnecessary and discriminatory. Okay. I also watched universal precautions led to rapid changes in how we dealt with blood. Wearing gloves for IV placement meant you couldn't feel veins as well. It was considered inappropriate to be ungloved contact with blood, and behaviors evolved in the 1990s and 1980s. So we did do some precautions. But he writes, a doctor who wears a mask with every patient is not singling out a patient or a disease. So the decision to wear a mask is completely impersonal, unlike the stigma against people with HIV. That's an important distinction. But I would push him a little bit and I'd ask him, and this actually happened to me in my training, what about, there was one person I was training with who every time we went to see a patient would always wear gloves before seeing any patient, even if this person didn't touch them. This person said, I wear gloves even if I touch the tray, because you never know if you touch the tray, there might be some blood on the tray, there might be something else on the tray. So this person wore gloves all the time. And I would say that's a completely impersonal decision. He's not singling out any patient. But you do look kind of crazy when you do that. I was like, it is kind of insulting to walk into someone and put on gloves and your suit and your hat. And if you came in, you could say, I always wear a hazmat suit. I wear a hazmat suit to every patient. It's completely impersonal. But if you started to do that, it would set the tone that what the hell is going on in here, So I think he makes an important distinction that if you discriminate person to person, that's problematic, especially if you're implementing a precaution that lacks evidence. But to me, it's not the case that if you don't discriminate, if you do the same thing for everyone, you're not actually succumbing to many of the concerns of Dr. Sarskian, which is that it's impersonal and, it's making the person feel stigmatized. They don't know you're doing it for everyone else, by the way. That's another problem here. Physicians who trained during COVID got as used to the shield of wearing a mask as I did to wearing gloves when touching blood. That shield may make them feel safe and comfortable, and they may be a better doctor for it. Okay, I don't know about that. And I think it's, okay, fine. It may let them hide their faces and emotions and be less awkward for it. Well, that's what I think the problem is that no one's talking about. There are a lot of young people who want to hide their face and emotions from other people because of their own personal anxiety. And this is a big, broad theater and a convenient excuse to hide your face from other people. And a lot of people want to commit criminal acts or go out and protest in illegal ways and things like that. And they want to wear a mask and they say COVID, 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 but it's also nice because it makes it harder to get caught. Am I wrong? It makes it harder to get caught. And so that's another thing here. A lot of these young people, particularly, I think, struggle to show their face and they need someone to push them to participate in normal things. And I think it will assuage their anxiety and things like that. It may interfere with communicating compassion and empathy and make patient interactions more fraught. So I think he concedes that. But I don't see the need to speak in absolutes or inflict my masking preferences on trainees. There's much else for them to learn. Yeah, I should say this. The other thing he says is, there's a comfort in wearing a mask when I occasionally sniffle or sneeze and wonder if I might be harboring some virus. Maybe you shouldn't be there at work, okay? But I think I'm doing my best to protect my patients. But I also really like having my face uncovered for my patients, and that preference wins. So he doesn't actually wear a mask. And then he says, it's not, I don't want to put my preferences on other people. So I think, he's pretty fair too. He's not going to try to push these young people away from it. What are my overall thoughts? My overall thoughts are one, the anecdotal experience when you're talking about a distribution that sort of has a right fat tail probability where the median is 8%, that even in household context studies, it's not 100%. When you start and you talk about an effect size of the intervention, it's 30%, your individual anecdotes probably have almost no credibility at all, and you should kind of take that down a notch in your mind. That's one. Two, I think medicine has to look around. Medicine can't be so elitist they don't understand where they're practicing. And I think this is the key point of Dr. Sarskian's. I'm working at a VA. People live hard lives. People don't give a shit about masks. Most patients at the VA, I would suspect, don't give a shit about masking, okay? And you walk in there and you're wearing a mask all the time. You're people are going to look at you like, where are you from? I'm out there in the movie theater. I'm out there in the clubs. I'm out there in the bar. I'm in a restaurant. No one is doing what you're doing. What are you doing this for? Are you sick? Are you trying to get me sick? Or you think I'm going to get you sick? Didn't you worried about me? You're scared? You can't handle a little respiratory virus? That's the other thing. At this point, SARS-CoV-2 is going to be there forever. We're all going to get it over and over again, probably every few years. Is the doctor fearful of getting it? Is the doctor fearful of giving it? That's another sort of thing I don't fully understand about this. The lack of evidence, of course, don't let that trouble you. I think that's a point she makes rather superbly. It shows that we're not good at assessing risk. But I think merely not fitting in with the broader society is a problem. It creates the appearance that medicine is some elitist profession that's increasingly bringing in people who are disconnected from reality. And in some ways, isn't that true? I mean, when I went to medical school, most kids coming into medical school hadn't published papers before. Most of us didn't start NGOs. I had worked as a bagger in a grocery store, bagging the groceries. I tell people that being a waitress or a waiter or bagger in a grocery store is the single best preparation you can have for being a doctor, because you actually are in a role where you have to think about the person who you're working to help, your customer business. And I think now we got students who are coming from 4 years of research or of other sort of costly and life experiences that aren't actually working a tough job. We set sort of impossible standards for entry. We keep raising the age for when people can get in. And we're creating a system where the students are increasingly elite, in my opinion. Although they talk a lot about having a diverse population, the one type of diversity that they're not really focused on is elitism. They have a lot of elites in there, and they have political homogeneity. They have people of one political party. And imagine you take somebody who's an extremely left-wing person, take them to a VA, they might encounter some personalities and points of view that they've not encountered before in their very sheltered, insulated lives at prestigious universities and at medical schools. And to top it all off, they're wearing a mask, which is a symbol of how different they are than the patients they're taking care of. And that, to me, is a problem. It's just yet another way how medicine is disconnected from the average American. And, at the time I was growing up in Northwest Indiana, a town called LaPorte, Indiana, some of you may know, near South Bend, near Notre Dame. I used to think, I wish I was growing up in a big city or some coastal place where it's more fun. Now that I'm older, I realize, there's a lot of good that it does you to grow up in a place like that. Like, all my high school friends are real people with real points of view, not deranged points of view. Not a single person I went to high school with would be caught dead wearing a mask in 2024. They wouldn't have been caught dead wearing a mask many years ago. They thought it was crazy for a long time. They thought the school closure going on forever was crazy. They sent their kids back to school early. They think masking a kiddo is crazy. They have a certain sense of common sense that escapes many highly elite people. And so I'm very grateful for having had that experience and being in touch with so many people I know from high school to sort of be an antidote to some of these ideas that pervade a place like the UCLA West LA VA, which I'm sure is enriched with the other phenotype because it is considered a very prestigious place to train. David Rind, I think he does make one good point, which is, are we willing to go that extra mile and say it's unprofessional if you hide your face? And he says, whatever, you do you, I do myself, whatever, we respect our boundaries. I think he's making a good point there, and that's also sort of where I've gravitated on this issue. Also, there's another point, which is that I'm a busy person. I don't have time to engage individual people. Sometimes, I'm walking around San Francisco, I still see people walking around on the sidewalk wearing masks. They usually appear to be very well-appearing and dressed in very rich people clothes and probably work in tech. And they're wearing masks, and I think to myself, that's pretty illogical. And sometimes somebody asks me, why don't you stop them and ask them? I was like, why don't I stop and ask them? I'm a busy person, right? Like, I got clinic, I got patients, I'm working on research papers, I'm working on some book. I'm a busy person. I don't got time to go asking people. And what are they going to say? Are they going to give me some magical, I don't know, they're going to say these things that everyone says and they say them online all day. I don't think they're going to have a unique reason why they're doing it. So I leave them alone and try not to talk about it too much because I think that gives them a lot of wind to continue these things. But the one reason that I'm still interested in this is that my hospital continues to this day mandated, which I think is absolutely insane. Absolutely insane. And if you're going to mandate something ever, you have a moral obligation to run a randomized control trial. Now, is there a randomized trial that swabbing all your stuff in chlorhexidine wipes will improve your outcome? No. So I think people are allowed to do personally crazy things that make them feel good. But I think Catherine makes a really good point, which is what messages it's sending our patients. And in the old days where professors had power and a professor could say, take that damn mask off, maybe I would have said it. But we live in 2024 where professors, of course, have no power at all. And if you said something like that, then they prevent you from ever working with a student again. So you can't say that. And so I just leave it alone for now. But I commend her for taking this stance. That's another problem, by the way, that the loss of ability for teachers and professors and people to actually set any rules, the shift in power, which I think has gone a little too far. All right, so those are my thoughts. Is it okay for internists to wear masks forever? And let's not speak in absolutes. There are 2 paired papers on sensible medicine. If you don't subscribe to Sensible Medicine, you should subscribe to Sensible Medicine. Why aren't you subscribing to Sensible Medicine? And while you're at it, subscribe to my Substack, Vinay Prasad's Observations and Thoughts. I had a good one this week about the CDC using basically the worst study from Oregon ever to justify, to exculpate the vaccine when it comes to cardiac deaths. And maybe I'll come back and do a video on that because I think that's an important topic as well. So if you like this video, you know what to do. Like, subscribe, comment, leave a message, send it to a friend, hit the notification bell. That's what people don't do. They're not hitting the notification bell. All right, I'll be back with more videos. Hope you enjoy this one.